So now starting with the chromosomal disorders is also a very, very important point. As we know that what is karyotyping, it is the study of the structure and number of the chromosomes. Karyotyping is a very important short note, but it is not given very nicely over here. So as I mentioned that I'm going to take up those topics separately because I need to put some inputs into this. So what happens is, how do we study this? Basically, we arrest the cells, we arrest the dividing cells in the metaphase with the mitotic spindle inhibitors, that is N-diacetyl N-methyl colchicine, which is the colcimide, and then we stain the chromosome, and then we observe that is basically a karyotyping. So any exact multiple of the haploid number of chromosome is called as euploid, but if it is not an exact multiple of 23, it is called as aneuploidy, which is basically, because of non-disjunction or anaphase lag. So if these chromosomes are separated in multiples of 2, but if there is 3 and if there is 1, then this is going to be n plus 1, this is going to be n minus 1. So this is basically your yes. So if you have an extra chromosome, it's n plus 1. If you have one less chromosome, it's n minus 1. This is because of non-disjunction, giving rise to aneuploidy. So what is mosaicism? The mitotic errors in the early development give rise to 2 or more population of cells with different chromosomal complement in the same individuals, a condition referring to as mosaicism. So mosaicism is basically when there's different chromosomal composition in the same individual. Okay. An error in the early mitotic division affecting the autosomes usually leads to a non-viable mosaic during autosomal monosomy. So if it is happening in the autosomes, then it is basically a non-viable condition. The zygote doesn't usually survive. But if it is in the sex chromosome, then the zygote usually survives. What we can see here is that FISH is a better method by which we can do this kind of study. Now, these points are also important to understand what is the meaning of a ring chromosome, what is inversion, what is isochromosome. So, what is ring chromosome? It's a special form of deletion in which a break occurs at both ends of a chromosome with fusion of the damaged end. So, if this is a chromosome, basically this part and this parts are broken down and then these two parts are joined. So this is a ring chromosome, it's forming a ring, but then these two parts are already broken or damaged. So this part is the ring chromosome. What is inversion? It refers to rearrangement that involves two breaks within a single chromosome with the reincorporation of the inverted intervening segment. So you can see here that, so this is the ring chromosome. As you can see, these two parts are destroyed and then this completely forms a ring. Inversion, you can see here that this part is just getting inverted and this part is just getting inverted. And what is this isochromosome? You can see here that it is being divided over here, and this part and this parts, these two are divided. This is deletion, obviously this part is getting deleted. And what is translocation? You have two types of translocation. One is the balanced reciprocal translocation and one is the Robertsonian translocation. So in the balanced reciprocal, what happens is that it is just this part is just getting transferred over here and this part is just getting transferred over here. So there is no loss of any genetic material. It is just that they are kind of getting translocated from their places. Therefore, it's called as balanced reciprocal translocation. There is no loss of genetic material. But in case of Robertsonian translocation, you can see that whenever, yes, there is kind of translocation, but some amount of genetic material is lost here. Okay, so I hope that these points are now clear to you. If you read this, it will make sense to you now. Okay, now all these syndromes are very, very important. So there are some cytogenetic disorders which are involving the autosomes and some which is involving the sex chromosomes. So in the autosomes, most important are the trisomy 21 or the Down syndrome. Along with that, we have the Patau syndrome and the Edwards syndrome. And we also have the Dye-George syndrome. And when we talk about the sex chromosomes, obviously we have the most important Klinefelter's syndrome, Turner's syndrome. Okay, so now we'll just go through these points very, very fast because there's nothing to understand here. Again, something which is not that concept based, but the points are really, really important. So just read this with me, that trisomy 21 or Down syndrome is the most common of the chromosomal disorders. It's a major cause of intellectual disability. Very, very important point. The most common cause of trisomy and therefore Down syndrome. It is the most common cause of meiotic disjunction. Important. Maternal age has gotten influence on that. So what is the molecular mechanism? Number one is the meiotic disjunction of the maternal chromosome, which is in 95% of the patient. It is of maternal origin. Number two is the Robertsonian translocation, which is happening in 4% of the cases, in which the long arm of chromosome 21 is being translocated to another acrocentric chromosome, which is 22 or 14. So because of this, you can see that 4% of Down syndrome are because of Robertsonian translocation. So again, a very important point. So you may get short notes on this, and you have to write about the molecular mechanism, what exactly are the genetics behind that. So number one is the meiotic non-disjunction of the maternal chromosome, which is the most common reason, which is accounting for 95% of the cases. The 4% of the cases is because of Robertsonian translocation, and 1% of the cases is because of the mosaicism. There's a mixture of the cells with 46 or 47 chromosomes. Okay. Clearly, in cases of translocation or mosaic, maternal age is of no importance. So very, very important point, very, very important point. In this mechanism, which is the meiotic non-disjunction, the maternal age is significant, is of importance. But if you talk about the Robertsonian translocation and if you talk about the mosaicism, then the maternal age is of no importance. And therefore, even in a mother who is having less age, there can be she can give birth to a baby having Turner syndrome, because maternal age is of no importance in 5% of the cases. The remaining 95% of the cases do have relation with maternal age. That is most common. Diagnostic features are flat facial profile, oblique palpebral fissures, epicanthic folds, and it's the leading cause for severe intellectual disability. However, there are some patients, if we talk about the mosaics, if the Down syndrome is because of the mosaicism, then the patients do not have much intellectual disability. Very important point. If mosaicism is the mechanism for this Down syndrome, then the patients will not have this kind of severe intellectual disability. The patients will have normal or near normal intelligence. Again, a very important point. Approximately 40% of patients, they have congenital heart disease, including the atrioventricular septal defects, accounting for 43% is the most common type, followed by ventricular septal defects, atrial septal defects, tetralogy of Fallot. Cardiac problems are responsible for most of the defaults, and they can also be atresia of the esophagus and small bowel. Very important, these patients have increased risk of developing leukemia. What kind of leukemia? It is basically AML, M7 or the megakaryocytic type, and they also have 20-fold risk of increased acute B lymphoblastic leukemia. Okay, so 500-fold increase means this is the most common type, which is the AML M7. This is having the highest predilection, and then this acute B lymphoblastic leukemia also has got an increased risk. And obviously, if these patients are more than 40 years of age, they will develop these neuropathologic changes, which is characteristic of Alzheimer's disease. These patients, they do develop Alzheimer's disease later on, and they also have abnormal immune responses, especially the T cell is getting affected over here. The median age of death is 47 years. Okay, so you can see here that these are mentioned. So in Down syndrome, you have this simian crease. Please compare and read. In Down syndrome, you have this simian crease, whereas in Edwards syndrome, you have these overlapping fingers, and in Patau syndrome, you have this polydactyly. ठीक है, तो फिंगर में क्या क्या डिफरेंस है? In Patau syndrome, you have polydactyly. In Edwards syndrome, you have overlapping fingers, and in Down syndrome you have the simian crease. You also have intestinal stenosis here, and you have the gap between the first and second toe. You have predisposition to leukemia. If you talk about the Edwards syndrome, you have renal malformations, you have micrognathia, you have rocker bottom feet. In Patau syndrome, you have polydactyly, cleft lip and palate, renal defects also there, rocker bottom feet is also there. So here you don't have rocker bottom feet. In Down syndrome, you have the gap between the first and the second toe. So these points are important. I've highlighted here. You can just go through it. Now coming to this chromosome 22q11.2 deletion syndrome, very, very important. This is basically the Dijot syndrome. But there's also another syndrome which is associated, which is the velocardiofacial syndrome. So let's read this, that because that this is a spectrum of disorders which result from small deletion of band Q11.2 on the long arm of chromosome 22. This include congenital heart defects, abnormalities of the palate, facial dysmorphism, developmental delay, and variable degrees of T cell immunodeficiency and hypocalcemia. Very, very important. Patients with, and these have two different disorders. Number one is Dye-George, number two is velocardiofacial syndrome, although the kind of mutation happening is almost same, and that is why they are put under the same category. The Dye-George syndrome patients have thymic hypoplasia resulting in T cell immunodeficiency. Very important point. They have thyroid hypoplasia giving rise to hypocalcemia. Very important point. They have cardiac malformations affecting the outflow tract and mild facial anomalies. They have atopic disorders, and they also have problems in autoimmunity. And if you talk about the velocardiofacial syndrome, then they especially have facial dysmorphism, which means prominent nose, retrognathia, cleft palate, cardiovascular anomalies, and learning disabilities, and they also have immunodeficiency. So in the MCQ, be very careful about these clinical features. They may point to velocardiofacial syndrome as well, because it has got the same kind of mutation happening in the Dye-George syndrome. The answer may not be Dye-George syndrome, because you need to pay attention to the clinical features very, very importantly. Now, another important point, individuals with this kind of relation syndrome, they are particularly at risk for psychotic disorders. Very, very important. What are the psychotic disorders? Schizophrenia and bipolar disorders that you can see here. You can also see this attention deficit hyperactivity disorders. Very, very important. These kind of detection can be done by FISH. Very important. Any kind of molecular detection, the most important diagnostic test is going to be FISH. Obviously karyotyping is there, but in the MCQs FISH will be a better option. Another important point is that if you talk about the TBX1 or a T-box transcription factor, it is most closely associated with the phenotypic features of this syndrome. This gene is expressed in the pharyngeal mesenchyme and endodermal pouch, from which facial structures, thymus and parathyroid are derived, and the targets of TBX1 include the PAX9 gene, which controls the development of palate, parathyroid and thymus. So TBX1, PAX9 are interconnected, and this is again interconnected with the Dye-George syndrome. So now coming to the disorders involving the sex chromosome, let me first talk about a small concept here, and that is the concept of lionization or inactivation. So basically what happens is that there is lionization or inactivation of one X chromosome. You know that is the concept of bar body, right? Bar body is X minus 1, number of X chromosome minus 1. So what is the concept of Lion hypothesis? This is the concept of X chromosome inactivation. See, only one of the X chromosome is genetically active. Okay, the other X chromosome, either of the paternal or maternal origin, they undergo heteropignosis and is rendered inactive. So only one of the X chromosome is active, the other X chromosome is always inactive. Inactivation of either the maternal or paternal X chromosome occurs at random among all cells of the blastocyst on the 5.5 day. Inactivation of the same X chromosome persists in all the cells derived from the precursor cell. So in the embryonic stage, one of the X chromosome is getting inactivated, and that is passed on to all the cells of the body. This inactive X chromosome can be seen in the interphase nucleus as a darkly stained small mass, which is known as the bar body. The molecular basis of X inactivation involves a unique gene called as the ZIST gene. Very important. ZIST gene is equivalent to X inactivation, whose product is a long non-coding RNA. Again, the same concept of gene silencing. So basically what's happening here is that one chromosome is getting inactivated, but in the disease involving the sex chromosome, you will see that this chromosome is not getting inactivated, and therefore the features or the clinical features are happening because of that, because of the fact that X chromosome is no more getting inactivated. There is no lionization happening over there. Now the gene which is responsible for the development of the testes or the testicular development is because of the SRY gene. Okay, some general points now. So in general, the sex chromosome disorders, they cause subtle chronic problems related to sexual development. Sex chromosome disorders are often difficult to diagnose at birth, and they may be recognized at the time of puberty. Very important point: the greater the number of X chromosome in both male and female, the greater the likelihood of intellectual disability. Very, very important. So I want to tell you one important thumb rule here, that if you find that the number of X chromosome is more, then that is equivalent to intellectual disability. Okay, and if you find that the number of Y chromosome is more, then this Y chromosome is responsible for some kind of carcinoma. Okay, some kind of, like, cancer in the gonads maybe. Okay, so that is how it is interlinked. Coming to the individual syndromes now, if you talk about the Klinefelter syndrome, it is a male hypogonadism. Why? Because there are 2 or more X chromosomes and 1 or more Y chromosome. There is aneuploidy and the impact of increased gene dosage by supernumerary X. So X is increased, and the presence of hypogonadism is rarely diagnosed before puberty. Now what's happening is that obviously they have an elongated body, unicoid body habitus with abnormally long legs, small atrophic testes associated with small penis, lack of secondary structures, gynecomastia may be present, type 2 diabetes may be present, atrial and ventricular septal defects, osteoporosis, hormonal imbalance. All of this can be present, and you can see that they also have this risk of developing germ cell tumors because the Y chromosome is also more over here, right? So it is an important cause of reduced spermatogenesis and male infertility. The tubules become atrophic over here. The Leydig cells become prominent. Again, an important point: Leydig cells become prominent, the tubules become atrophic. Important point. All the tubules are primitive and appear embryonic, consisting only of cords of cells that have never developed, and therefore there is no mature spermatogenesis happening over here. You can see that the level of FSH is elevated and testosterone levels is reduced. Estradiol levels are also increased. Classical Klinefelter syndrome have this karyotype 47XXY, and it results from non-disjunction during the meiotic division of any of these parents. There is no difference whether this X chromosome is derived from the mother or the father, whoever it is the same. Advanced maternal age is a risk factor. Obviously, non-disjunction at the first meiotic division is the genetic mechanism, but it is also because of some kind of mosaicism happening in 15% of the cases. So this is the gene which is involved, that is the SHOX gene, or the short stature homeobox gene. Now coming to the Turner's syndrome, very, very important. There is a complete or partial monosomy of the X chromosome characterized by hypogonadism in the females. Now what are the karyotypic abnormalities seen in Turner's syndrome? There are 3 types you can see here. 57% of them is missing an entire X chromosome. 14% of them is having an abnormal structure of X chromosome. 29% of them is because of mosaics. Now, what are the structural abnormalities? They can be isochromosome, ring chromosome, and deletion of a portion of the short or the long arm. I've already explained all these mechanisms before. You just need to remember these points. See, this is the first point, where they're missing an entire X chromosome. Number 2 is they have a structural abnormality, and number 3 is that they have mosaicism. Now 5% to 10% of these patients, they have Y chromosome sequences. Okay, like you can see 45X or 46XY chromosome. Whenever this Y will come, as I have mentioned, that there is an increased risk for carcinoma. So these patients who have got an extra Y chromosome, these patients are at increased risk for development of gonadal tumor or gonadoblastoma. So Y chromosome agar hai, then that will give rise to gonadoblastoma in Turner syndrome. Very important. The other features obviously include that they have edema of the dorsum of the hand and the foot due to lymph stasis, bilateral neck webbing, congenital heart disease. They also have aortic root dilatation, and therefore they have 100-fold higher risk of aortic dissection. Very, very important point. At puberty, there is a failure to develop this normal secondary sexual characteristics. The mental status is usually normal. Very important. There is a short stature with amenorrhea. Turner syndrome is the single most important cause of primary amenorrhea. Very, very important. In gynecology, you will be reading about these various reasons or mechanisms why amenorrhea takes place. There are various syndromes associated with that, out of which this is a very important syndrome. 50% of them, they develop autoantibodies, and therefore they have hypothyroidism, they have all the other metabolic disorders, they have a full-fledged metabolic syndrome. They have got streak ovaries, again a very important point. The genes involved are the SHOX gene. Haploinsufficiency of this SHOX in Turner syndrome is believed to give rise to a short stature. So because of this, the short stature can be explained. Very, very important point. So what is a true hermaphrodite? It implies the presence of an ovary and a testicular tissue in the same individual. Okay. But what is a pseudo hermaphrodite? They will have different genitalia and different internal gonads. So a female pseudo hermaphrodite will have ovaries, but they have male external genitalia. This is called a pseudo hermaphrodite. But what's a true hermaphrodite? They will have the ovarian and testicular tissue together within themselves. You understand?